Hi, everyone. Thank you for your attention. I've been asked to give this presentation titled Best Management Strategies in Acute Pancreatitis. My name is David Jen. I'm one of the medical pancreatologists at Brigham and Women's Hospital. I have no relevant disclosures. So the agenda of my talk today will be broken up into 5 parts, starting with etiology. Then we're going to move on to how we diagnose acute pancreatitis, how we classify severity, how we manage the disease, and also factors to consider at discharge. So acute pancreatitis is a very common problem. It's actually the third most common admission diagnosis amongst all GI disorders in the United States, accounting for nearly 300,000 hospitalizations per year in this country. It leads to $3 billion in aggregate cost per year, $26,000 in charges per hospitalization, and the incidence is actually increasing worldwide by more than 3% per year. So what I want to impress upon you is that most cases of acute pancreatitis looks like this. This is a contrast-enhanced CT scan of a patient with mild interstitial pancreatitis. You'll notice the arrows pointing to a pancreas that is relatively well enhancing, but there is a bit of surrounding inflammatory fat stranding. This is interstitial pancreatitis. It accounts for the vast majority, 85% of all cases. Mortality in this phenotype is extremely low, of less than 1%, and an average length of stay typically lasts 3 to 5 days. Contrast that with this patient who had severe acute pancreatitis, now with infected pancreatic necrosis. So the yellow arrow here points to an infected necrotic collection. You see very, very little normal pancreatic tissue. In its place, you have necrotic debris with gas, including an air fluid level. This represents less than 5% of all cases of acute pancreatitis, but the mortality is substantially higher, greater than 30%. These are the patients who often spend weeks, if not months, in the hospital. So let's talk about etiology of acute pancreatitis, starting with a question. You see a 45-year-old male with Crohn's disease on azathioprine who's admitted for acute pancreatitis. CT shows diffuse peripancreatic stranding and gallstones. He consumes 4 alcoholic drinks per week. His ALT is 200, triglycerides are 200. The most likely etiology of acute pancreatitis is A, gallstones, B, alcohol. Is it C, Crohn's disease, D, azathioprine, or E, autoimmune pancreatitis? The best answer here is gallstone pancreatitis. So when it comes to etiology, the vast majority can be explained by 3 things: biliary or gallstone pancreatitis. If you see an ALT of greater than 150 at presentation, that actually has a 95% positive predictive value for gallstones being the etiology. Second most common etiology in the United States is alcohol, usually in patients who chronically consume more than 50 grams. It's about 4 to 5 alcoholic drinks per day. In these patients, we have a biomarker called phosphatidylethanol, PEth score, PEth level that gives us a rough idea of how much alcohol a patient may have been consuming over the prior 2 to 4 weeks. Third most common etiology is high triglycerides, typically a fasting triglyceride level greater than 1,000. Very rarely is pancreatitis caused by medications, drugs. These are typically idiosyncratic, mild episodes, and they're almost never the cause of pancreatitis, with the exception of immune checkpoint inhibitors. Autoimmune pancreatitis, type 1, is IgG4-related disease, rarely presents with acute pancreatitis, and more often acute presents as a mass lesion, leading to painless jaundice. In about 10 to 25% of cases, there's no readily identifiable etiology. These are termed idiopathic. These patients may benefit from an endoscopic ultrasound or an MRCP afterwards. Typically, 30% will show gallstones as the underlying cause, but a small percentage will show underlying pancreatic neoplasia. So it is my practice that in all patients with idiopathic acute pancreatitis, they get either an MRCP or EUS, typically 1 to 2 months after, to evaluate for underlying cancer. So the take-home point when it comes to etiology is that gallstones, alcohol, and triglycerides explain greater than 75% of cases. When it's idiopathic, make sure you follow them up with an MRI or EUS. You can also check a PEth level, and it's almost never drug-induced. How do we diagnose acute pancreatitis? Diagnose according to this. Well, let's start off with a question. What percentage of acute pancreatitis presents with characteristic pain? So that's severe epigastric pain, often radiating to the back, plus an elevated serum lipase of greater than 3 times the upper limit of normal, thereby obviating the need for diagnostic imaging. Is it A, 90%, B, 50%, C, 20%, D, 5%, or E, 1%? The answer here is A, 90%. So let's review the diagnostic criteria. So a patient requires fulfilling at least 2 of the following 3. One is characteristic abdominal pain. The second is a serum amylase or lipase greater than 3 times normal. The third being a CT or MRI showing characteristic changes of acute pancreatitis. But you actually only need 2 out of the following 3. And 90% of patients actually meet the first 2 criteria at presentation, thereby already fulfilling a diagnosis of acute pancreatitis. And despite this, a CT, an early CT scan, is actually performed in 40 to 70% at presentation, typically within the first few hours in the emergency department. And this is performed despite multiple studies and clinical guidelines showing that early CT imaging in acute pancreatitis does not improve clinical outcomes, does not influence treatment. It's not superior to clinical scoring systems in predicting severity, has low yield without any direct management implications. And CT contrast poses risk of contrast allergy and nephrotoxicity. So this is actually an area of research for me and our group. And this is one potential option or tool that we've developed to help one diagnose pancreatitis without resorting to early confirmatory CT imaging. It's a diagnostic score we derived using patients at the Brigham, and one we've recently prospectively validated using patients at Brigham and MGH. It's a score comprising of 8 separate predictors, including the number of prior pancreatitis episodes, a history of gallstones, recent abdominal surgery, the location, the progression, the duration, severity of pain, as well as their initial serum lipase value. And we found this score to be very accurate when it comes to differentiating between acute pancreatitis versus non-pancreatic pathology. And a score of greater than 6 had fairly high sensitivity, specificity, positive predictive and negative predictive values for the diagnosis of acute pancreatitis. In patients who scored greater than 6, only 7% of early imaging revealed an alternative diagnosis, and very few, 0.3%, had a serious alternative diagnosis, which was one case of small bowel obstruction. So this is a tool we can employ nowadays as a way to avoid CT imaging, especially early on in the disease. So my take-home point when it comes to diagnosis is that in patients presenting with characteristic abdominal pain and a serum lipase greater than 3 times normal, and who are not actively deteriorating before your eyes, consider deferring early CT imaging. Let's move on and talk about severity, starting with another question. Which patient has the highest predicted mortality? Is it Adam, who has biliary pancreatitis but no organ failure? Is it Billy, who has alcoholic pancreatitis and acute kidney injury for 36 hours? Is it Charlie, who presents with hypertriglyceridemia, induced necrotizing pancreatitis, fevers, but no organ failure? Or is it Dustin, who presents with post-ERCP acute pancreatitis and 72 hours of hypoxia. The best answer here is D, Dustin, who presents with post-ERCP pancreatitis and 72 hours of hypoxia. So let's talk about severity, starting with how we classify severity. And we do that by stratifying patients into mild, moderate, or severe disease. Mild is defined by the absence of organ failure. Moderately severe acute pancreatitis is defined by transient organ failure, which lasts no more than 48 hours, or by the presence of local complications, which I'll define in a minute. Severe acute pancreatitis is defined by persistent organ failure lasting greater than 48 hours. Organ failure itself is defined according to the modified Marshall scoring system and represents three separate organ systems: the cardiac system, respiratory system, and renal system. I did mention local complications as part of moderately severe pancreatitis. These typically represent pancreatic or peripancreatic fluid collections, such as acute peripancreatic fluid collections, APFCs, acute necrotic collections, pseudocysts, and walled-off necrosis. There are additional local complications that can arise, including gastric outlet obstruction, as well as splenic or portal vein thrombosis. Let's define these pancreatic fluid collections a bit more. They can be thought of in terms of what phenotype of pancreatitis a patient has. Is it interstitial or is it necrotizing? And also how early or late the patient is in their disease course. So if a patient presented with interstitial pancreatitis and are within 4 weeks of presentation, they may develop acute peripancreatic fluid collections, or APFCs. After 4 weeks, the APFCs may organize into a pseudocyst. On the contrary, if a patient presents with necrotizing acute pancreatitis, within the first 4 weeks, they may have a acute necrotic collection, or ANC. And after 4 weeks, acute necrotic collections may organize into a walled-off necrosis. So let's look at some CTs showing these different types of local complications. This is the first CT I showed you of a patient with interstitial pancreatitis. Again, the pancreas is well enhancing. Surrounding it, there is inflammatory fat stranding, but there's no evidence of necrosis. This is another patient with interstitial pancreatitis who has developed APFCs, or acute peripancreatic fluid collections. You see some fluid anterior to the pancreas in the lesser sac. There's some additional fluid behind the pancreas here, surrounding the left kidney. These are serous, homogeneous, poorly organized fluid collections that obey fascial planes. The pancreas itself remains well enhancing. There's no necrosis. This is a case of interstitial acute pancreatitis with acute peripancreatic fluid collections. Later on, the same patient may organize these APFCs into a singular collection with a wall or a pseudocyst. This is a homogeneous fluid collection that is organized into a pseudocyst. The pancreas, marked by these stars, remains well enhancing. There's no evidence of recent necrosis. In contrast is the patient who presents with necrotizing pancreatitis and has an acute necrotic collection. You see there's very little enhancing pancreas left. In fact, the pancreas itself, marked by these stars, is hypoenhancing. There's a little bit of normal pancreatic tissue marked by the black arrow here in the tail of the pancreas. And anterior to the pancreas, you see an acute necrotic collection. This is a heterogeneous collection. You see there are bright and darker areas. If you were to obtain an MRI of a patient with acute necrotizing pancreatitis, this really highlights how heterogeneous the collection is. The bright areas on this T2 weighted sequence represents liquid, whereas the darker areas represent necrotic debris. After about 4 weeks, the patient with necrotizing pancreatitis may form a walled-off necrotic collection or walled-off necrosis. This is a heterogeneous fluid collection that's formed this rind, if you will. It's organized, and at this point, it is ready to be intervened upon with endoscopic, percutaneous, or even surgical drainage if clinically indicated. So just to review, pancreatitis, acute pancreatitis is stratified into mild, moderate, severe disease. Mild being the absence of organ failure, moderate representing transient organ failure, and severe disease representing persistent organ failure. You'll notice that just because someone has necrotizing pancreatitis does not necessarily mean they have severe pancreatitis. Rarely there are cases of necrotizing pancreatitis who do not develop organ failure. The reason why this is important is because it's really organ failure that's the primary determinant of mortality, not necrosis. So you'll see that in mild acute pancreatitis, there's essentially no mortality. In moderately severe acute pancreatitis, mortality remains low at 1 to 3%. But in severe acute pancreatitis, i.e. persistent organ failure lasting more than 48 hours, mortality rates are much higher. And they're higher when multiple organ systems are involved. Here's another question. Who is most at risk for severe acute pancreatitis? Is it Ashley who presents with, is it Ashley who has a history of necrotizing acute pancreatitis, who now presents with recurrent acute pancreatitis on the remaining head of the pancreas? Is it Brenda who has biliary acute pancreatitis, hematocrit of 47%, BUN of 35, and meets SIRS criteria? Is it Carla who presents with alcoholic acute pancreatitis, hematocrit of 31%, BUN of 18, and no SIRS? Or is it Dina who presents with painless jaundice and an elevated IgG4 level? Best answer here is B, Brenda, who presents with biliary acute pancreatitis, an elevated hematocrit, elevated BUN, and SIRS. So what are some risk factors for a patient developing severe disease? Well, even before they hit the hospital, there are potential risk factors, including older age, which has been shown to increase mortality in severe disease. Comorbid disease, things like heart failure and COPD have been shown to increase mortality and organ failure. Obesity with a BMI greater than 30 probably triples the odds of persistent organ failure and doubles the odds of mortality. Importantly, essentially 100% of mortality in acute pancreatitis occurs with the first episode, and recurrent episodes of pancreatitis have negligible mortality. Whether etiology plays a role in mortality is a bit controversial. There have been a few studies that have shown alcoholic pancreatitis and hypertriglyceridemia-induced pancreatitis may have higher odds of mortality compared to other etiologies. All right, so what biomarkers at admission may help predict severe disease? Probably the one we use most often are the SIRS criteria. So just to review, SIRS requires 2 of the following 4 criteria: a heart rate over 90, a temperature less than 36 or greater than 38 degrees Celsius, presence of leukopenia or leukocytosis, or respiratory rate greater than 20, or PCO2 less than 32 millimeters of mercury. This was a single center prospective study done at the Brigham, looking at SIRS criteria in acute pancreatitis. And this study showed that for each additional SIRS criteria that was met within the first 24 hours, the odds of the rates of persistent organ failure, pancreatic necrosis, need for intensive care unit, and mortality increased. This is a multi-center prospective cohort study looking at serum blood urea and nitrogen in patients presenting with acute pancreatitis. The study found that for every 5 milligram per deciliter increase in admission BUN, the odds of mortality tripled. And for every 5 milligram per deciliter increase after 24 hours of emission, the odds of mortality doubled. So BUN is thought to represent human concentration and third spacing, especially high BUN levels. So it's relevant because those presenting with high BUN who subsequently increase are at a particular risk for organ failure and mortality. So a lot of these different biomarkers have been packaged into different severity prediction scores. You've probably all heard of the Ranson criteria, which comprises 11 parameters, 5 at admission, 6 after 48 hours. It's a bit cumbersome to calculate, so it's not done very often, but there are other prediction scores which are a little bit easier to calculate. There's Apache 2, there's the BISAP score, which is developed at the Brigham. There's a harmless acute pancreatitis score, which actually predicts a harmless disease course. And then there's the newest one, which is the PASS score, which I'll highlight. The PASS stands for the Pancreatitis Activity Scoring System. It's a daily dynamic measurement of disease activity. So it's a 5-part weighted score you can calculate at admission and every day. And here on the right is a plot of patients with severe acute pancreatitis, the top line. These patients often present with a very high PASS score and it remains elevated sometimes for weeks. And the 2 lines on the bottom actually represent moderately severe or mild acute pancreatitis. And these patients have PASS scores that quickly drop within the first day or two and remain relatively low up until discharge. PASS score has been validated prospectively. This one study shows that elevated admission PASS is associated with the development of moderately severe or severe pancreatitis later on the disease course. And an elevated PASS at discharge is actually a predictor of early readmission within 30 days. So take-home points when it comes to severity. The mortality in recurrent acute pancreatitis is 0%. Nearly all mortality occurs with the first episode. You should evaluate for markers of severity at admission. These include SIRS and BUN, also hematocrit, which we didn't talk about. Should be monitoring for signs of organ failure, and that there's any suggestion of organ failure, these are patients who should be managed in the ICU. And PASS scores should be calculated, especially at admission within the first 1 or 2 days and potentially at discharge. So let's talk about how we manage acute pancreatitis with another question. It's a 50-year-old male presents with epigastric pain, elevated lipase of 3,000, ALT of 300, total bilirubin is 0.8, white blood cell count of 9. He is afebrile, heart rate is 90, blood pressure is 120/80, respiratory rate is 12, and he sets 98% on room air. Right upper quadrant ultrasound showed gallstones and a normal CBD caliber of 6 millimeters. Best practices are to A, keep the patient NPO until all pain is resolved. B, administer prophylactic antibiotics to reduce the risk of cholangitis. C, proceed to ERCP for suspected choledocholithiasis. D, consult surgery for same admission cholecystectomy. Or E, bolus IV fluids, 20 cc's per kilo. So there's the patient who presents with acute pancreatitis. We know that because there is characteristic abdominal pain, there's an elevated lipase. This is a patient who would not require confirmatory diagnostic CT imaging. In terms of etiology, he has an ALT of greater than 150, which is highly predictive of gallstone pancreatitis. We do know that he has gallstones remaining in his gallbladder. Other than that, it seems like he has mild disease. There's no evidence of organ failure. So the correct answer here actually is D, consult surgery for same admission cholecystectomy. All right, so let's start talking about management with fluids. So as we all know, IV fluids is the mainstay of treatment for acute pancreatitis. And when it comes to fluids, earlier fluid resuscitation is probably better than delayed fluid resuscitation. This is a retrospective cohort study showing that patients who received early IV fluids, defined as greater than a third of their total 72-hour volume within the first 24 hours, these patients had decreased rates of SIRS as well as decreased ICU requirements compared to those who, for whatever reason, received delayed IV fluids. When it comes to type of IV fluids, lactated ringers is probably better than normal saline. This was a small RCT performed at the Brigham, comparing LR to normal saline. And the study authors found that lactated ringers was associated with decreased rates of STIRS at 24 hours compared to normal saline. What about rate of IV fluids? This was always had been controversial for a long time, up until the publication of the Waterfall trial in 2022. This was a multi-center randomized controlled trial comparing aggressive versus moderate IV fluids for mild acute pancreatitis. Primary outcome was the development of moderate or severe disease. This was the protocol. So half patients were randomized to aggressive IV fluids. These patients were bolused at 20 cc's per kilo and then started on a maintenance fluid regimen of 3 cc's per kilo per hour. The other half were randomized to the moderate resuscitation group. They essentially received half of that. They were bolused by 10 cc's per kilo or no bolus if they were euvolemic, and then they were maintained on 1.5 cc's per kilo per hour. There were various safety checkpoints as well as goal-directed checkpoints. So this RCT was actually terminated early because it met the safety checkpoint prior to their planned sample size. So in the aggressive IV fluid group, 21% of them developed fluid overload versus only 6% in the moderate IV fluid resuscitation group with a relative risk of 2.85. And there was no difference in development of moderate or severe disease at that point when comparing the two groups. So because of that, we've really transitioned to moderately aggressive goal-directed IV fluids, especially for mild acute pancreatitis. So in the vast majority of patients, they should be receiving a 10 cc per kilo bolus, or if they're euvolemic, no bolus, and then maintain on 1.5 cc's per kilo per hour, adjusted to goal-directed checkpoints. And when it comes to type of IV fluids, lactated ringers remain preferred. What about nutrition? We know that early oral feeding as tolerated is better than keeping a patient NPO now. Oral feeding protects the gut mucosal barrier and reduces the risk of bacterial translocation. There have been at least 11 randomized trials looking at this, showing that oral feeding actually decreases the interventions needed for necrosis without increasing mortality, organ failure, necrosis. Of course, there are some patients who cannot tolerate oral feeding for a prolonged period of time for a variety of reasons. And if they need supplemental nutrition, then enteral feeding is clearly better than parenteral nutrition. There have been 12 RCTs looking at this, which have shown enteral feeding decreases the risk of infected necrosis, decreases rates of organ failure without any difference in mortality. And when it comes to enteral feeding, it can be done via a nasogastric or nasojejunal tube. Feeding does not have to be post-pyloric or into the jejunum. There have been 3 RCTs looking at this. There's no difference in mortality, no difference in organ failure, no difference in rates of necrosis. So when it comes to nutrition, the take-home point is to avoid routine NPO orders. You can go ahead and feed the patient whenever they're hungry, and it's okay to start with a solid diet. There's no need to advance slowly over days. And if a patient is unable to tolerate oral feeding, then NG or NJ feeding is appropriate. Is there any role of prophylactic antibiotics for acute pancreatitis? The answer is no. There have been multiple RCTs looking at this specific question. Prophylactic antibiotics does not reduce mortality or rates of infected necrosis or non-pancreatic infections or the need for surgical interventions. There is no role for antibiotic prophylaxis. Antibiotics should only be reserved in patients with cholangitis or documented infected necrosis. What about role of early ERCP or sphincterotomy in acute gallstone pancreatitis? There have been multiple RCTs looking at this question, comparing early ERCP versus conservative management for these patients. They have found no difference in mortality or complications in mild disease or predicted severe disease. So in general, we do not perform early ERCP for gallstone pancreatitis unless there's concurrent cholangitis or if there's a CBD stone that does not spontaneously pass after 24 hours. What about patients presenting with gallstone pancreatitis and the question of same admission versus interval cholecystectomy? So this is a multi-center RCT done in Europe called the Poncho trial, randomizing patients into same admission cholecystectomy versus discharge and then outpatient cholecystectomy. Their primary composite outcome was readmission rates at 6 months for a biliary complication or mortality. So the same admission cohort got their cholecystectomy within a day on average versus the interval cholecystectomy group. They were discharged and got their cholecystectomy 27 days after initial presentation. You'll see that the primary outcome was significantly higher in the interval cholecystectomy group, and half of patients who were in the interval cholecystectomy group were reporting biliary colic while waiting for the cholecystectomy. This group also performed a cost effectiveness analysis on this, and they found a negative incremental cost effectiveness ratio. In other words, you would be saving 1,900 euros to prevent one readmission for biliary complications. So this is really a no-brainer. You're preventing readmission and you're saving costs. And how do we manage necrosis? Well, the first point I'll make is that sterile necrosis and pseudocysts almost never require early intervention, and they only require intervention if they're symptomatic. So if they're causing persistent pain, anorexia, nausea, and this typically occurs later in the disease course. If a sterile necrotic collection or a pseudocyst does not cause symptoms, they do not require intervention. In fact, a third of them will resolve spontaneously. But of course, infected necrosis needs to be acted upon. This typically peaks 2 to 4 weeks after presentation. You should suspect this in patients who develop sepsis, SIRS, or organ failure after 7 days of onset. It's proven either with culturing gram stain of necrotic aspirate or the presence of gas within the collection on imaging. The treatment of infected necrosis has evolved. It used to be treated with early surgery, which then evolved to delayed surgery, which then evolved to step-up surgical approach. And nowadays we use a endoscopic step-up approach. So this is actually one of the first RCTs I found related to the management of infected necrosis. This study randomized patients into early laparotomy, early open surgery versus delayed surgery, early within the first 72 hours versus delayed after 12 days. And you'll see significantly improved mortality in the late surgical cohort. But look at these mortality rates in those undergoing early surgery. The mortality was 56%. And if the patient had infected necrosis, 73% mortality in early surgery versus 29% in delayed surgery. This was a seminal trial comparing primary open surgery, open surgical necrosectomy versus a surgical step-up approach, which employs first percutaneous drains followed by video-assisted retroperitoneal debridement, type of minimally invasive surgery. The primary composite outcome is listed here, and they found significant improved outcomes in the step-up approach. And also significantly improved or lower rates of multi-organ failure, the number of total surgical operations, as well as costs. Nowadays, as I mentioned, we use an endoscopic step-up approach, which typically involves EUS-guided drainage, followed by endoscopic necrosectomy. This is one study that compares the endoscopic approach versus the surgical step-up approach, and you'll see improved outcomes in the endoscopic group as well as decreased cost. So this is an example of a patient who presented with acute necrotizing pancreatitis on day 0. You see some hypoenhancement of the pancreatic gland with a substantial amount of peripancreatic fat stranding. By day 7, you see near complete obliteration of the pancreas. And now you have a acute necrotic collection that has taken the place of the pancreas. This necrotic collection is going all the way down the left paracolic gutter. About 4 weeks in, you'll notice that this acute necrotic collection is organized into a walled-off necrotic cavity. At that point, it was minimal to drainage. This patient underwent first endoscopic drainage, followed by debridement. On the left here, you'll see a lumen-opposing stent as well as a plastic stent going into this necrotic cavity. You'll notice a bunch of gas within the collection, indicating infected pancreatic necrosis. And this is 51 days, multiple endoscopic debridements, as well as multiple percutaneous drains, finally showing some improvement in the walled-off necrotic collection. So what factors should we think about at discharge? Well, there's certainly an impact of alcohol and smoking. The NAPS2 consortium, which comprises 20 US centers, showed that not only does one episode of acute pancreatitis increase the risk of chronic pancreatitis, but that risk was substantially higher in those who used very heavy alcohol or continued to smoke. There was actually a RCT looking at patients with acute alcoholic pancreatitis, randomizing them into initial versus repeat alcohol cessation counseling. Patients in the repeat counseling arm had significantly reduced rates of recurrent acute pancreatitis. So these are patients in whom alcohol and smoking cessation counseling should be provided. There's also a risk of pancreatic insufficiency, both endocrine and exocrine insufficiency. The pooled prevalence of diabetes after a single episode of acute pancreatitis is 15% within the first year and actually increases to 40% after 5 years. Similarly, there's a risk of exocrine pancreatic insufficiency of 42% after an episode of acute pancreatitis. And the rates here are highest in those with alcoholic disease, severe disease, or necrotizing disease. The take-home point here is that in some patients, especially those with severe necrotizing pancreatitis, they should probably be discharged on pancreatic enzymes. And all patients with pancreatitis should be screened for diabetes and exocrine pancreatic insufficiency at follow-up. So I just want to end with this slide, which helps to summarize a lot of these management strategies, and also to prove that these guidelines, they actually matter. So when it comes to things like, should we perform early diagnostic imaging? Should we be avoiding TPN and antibiotics and early ERCP and early surgery? You'll notice that, at least in this one study, a lot of these different guidelines were associated with reduction in mortality, reduction in length of stay, as well as overall reduction in total costs. So the take-home points for this lecture are: one, utilize early diagnostic CT judiciously; two, to evaluate for early markers of severity; three, to document persistent organ failure; four, to provide early goal-directed fluid resuscitation; five, to initiate early oral feeding when tolerated, regardless of severity; six, to choose enteral rather than parenteral nutrition if a patient is unable to tolerate oral feeding; seven, to avoid prophylactic antibiotics and early ERCP; eight, to drain or debride endoscopically infected or symptomatic necrosis; nine, to perform early cholecystectomy for mild gallstone pancreatitis; 10, to discontinue alcohol and smoking; and 11, to screen for diabetes or exocrine pancreatic insufficiency at follow-up. So thank you so much for your attention today. This is my contact information if you have any questions or if you want to refer any patients to our pancreas clinic. Thank you very much.